Hello, my name is Clara Anderson Sante with Gilda's Club Kansas City in partnership with Turning Point. We're very honored and happy to have Sabrina and Marcia here with us today to discuss living with lymphedema. Go ahead, Sabrina.
Hi, good morning. If you can't hear me for some reason, please raise your hand or let me know. I have the luxury of being at home today, but sometimes that means that I'm in an area where the Wi-Fi likes to go in and out. So hopefully everyone hears me nice and clear. Um, as she mentioned, I'm Sabrina Korentager. I currently am at the University of Kansas Cancer Center. And today we're going to talk a little bit about what I like to call myths, facts, prevention, early detection, and intervention. So there's a little bit of a bucket of everything going on today. So a little bit about myself. This summer, I'll hit my 28th year of nursing. I started out in cardiac nursing for about 15 years, moved over to cancer research, had a very brief stint in administration and missed patients. So went back and in late 2013, early 2014, collaborated to start the lymphedema prevention program that we have now at the University of Kansas Cancer Center. The focus has been really different for us. Rather than focus on treatment, which speaking after me is Marcia, who is an expert in treatment, we are focusing on early detection, intervention, prevention, and education. So one of the first in the country to do this. And so it's been a unique few years with all of this, but we've seen really good things. As I was looking through the names today, I was really excited to see a lot of you. A lot of new names I'm not familiar with, a few names I'm really familiar with that I'm always excited to see. So a little bit of what we're going to talk about today. What is lymphedema? Stages of breast cancer related lymphedema. As I mentioned, some myths and facts, what risk factors you might have or someone that you know might have for the development. What are some risk reduction recommendations? Prevention and early detection. I'm going to speak just for a few minutes about what we're doing at KU. I recognize that we have some KU patients in this mix, but some that aren't. So there's a little bit of something for everything, some interventions. And then I do have a little bit of a brief topic about some of the surgical interventions that are available to patients with actual lymphedema. I don't spend much time on that because obviously that's a surgical procedure by a surgeon, but I do certainly mention it. So the lymphatic system, because I think it's important that we talk about our lymph nodes since that's what causes all of this disruption in our body anyway. So our lymphatic system is a transport system. It really is a filter. It helps to maintain fluids, it helps to filter fluids, and it's part of our healing response as well. So as you can see here, it's really what helps to clean all the fluid out and then it returns it back into the body. It works in combination with our circulatory, AKA heart system. I always joked that the study of lymphedema and the lymphatics was a perfect match for me after being a cardiac nurse. It really put everything into perspective having had that background. And so I always laugh about that. So how does it work? Well, when we meet with patients, we kind of describe it as a lazy river or this kind of slow moving osmotic process. But really what happens is these capillaries really tend to deliver the fluid and they come into these valves of the heart system. And so really it's a pretty good closed system that allows the body to be pretty darn efficient through an osmotic process. And when that doesn't happen, what happens is the fluid that it was moving isn't able to anymore. I kind of describe that as a lazy river that gets too many inner tubes in it. They all start to bunch up and none of them are able to move through the system. And so when that happens, then we have all of this blockage in our lazy river. So how does that happen in breast cancer? What we commonly refer to as BCRL, breast cancer related lymphedema. Sometimes you'll see that in the literature or you'll see that in handouts that are given to you from your surgeon or your oncologist, that term BCRL, that stands for breast cancer related lymphedema. Well, breast cancer lymphedema can happen when any part of our normal system in that area can be blocked or damaged. This can happen if we remove lymph nodes, chemotherapy, radiation, injury, or trauma. And so, again, I kind of use the highway system analogy or lazy river system. Things get confused that are normally used to moving in one direction. They get disrupted as any of these can happen. undergoing breast cancer treatment, most of you will have experienced at least one of these, if not all of these things, as part of your treatment. When we talk about lymphedema and how it can happen in the stages, we actually have 4 stages. Many people are not familiar that there are 4 stages. Many people, when they commonly think of the word lymphedema, they think of what we see on stage 2 and stage 3. One of the first questions when I'm working with patients in the clinic is, I always say, tell me what you know about lymphedema. I do that because almost always somebody will say large swollen arm. That's traditionally, historically, what we have thought about. But honestly, there's a stage 0 and a stage 1. And you can see that I delineated them out in that stage 0 and stage 1 are actually what we call early lymphedema, and they're reversible. Interestingly, when we look at the stage 0, which is all the way to the left-hand side, when you look at this individual, they look perfectly fine, as if nothing's going on. And from a clinical, meaning looking at them, walking into the room, that's true. They look completely like there's nothing going on. There's something going on underneath. The inner tubes are starting to have problems. They're starting to bunch up, and the resistance in that lazy river is starting to really climb. So what happens if we don't do something? Well, for some people, the swelling stays mild, but for a lot of people, chronic, what we call long-term chronic lymphedema, can lead to a lot of problems. And this is actually one reason why I became interested in this area, was because it became a quality of life for patients. I was working in research and had met many people that had had long-term chronic lymphedema. Many of them had a loss of their ability to do normal daily things. I had one patient that she was an accountant for her job, and she wasn't able to do a lot of her accounting because of the swelling in her hand and forearm. And I thought, gosh, that's really impactful on her life. And so many patients that don't receive treatment or aren't able to get their treatment of lymphedema under control experience some of these things long-term. They're susceptible to chronic cellulitis, which is an infection. They're susceptible to chronic pain, loss of mobility in the area. And then again, as I mentioned, they're not able to have their normal activity, what we call activities of daily living, or ADLs. Some of them end up even being unable to work. So now that we know what lymphedema is and kind of what the stages are, what are some myths and facts? And before I go to the next slide, I want you all to kind of think about, when you started your journey, what were some things you thought about when you heard the word lymphedema as it relates to breast cancer? Because probably if I took a poll, all of you are going to have something off my myth side that kind of says, yeah, I thought that. And honestly, I thought that too when I started this job. So what are some myths? Lymphedema isn't preventable. Lymphedema isn't reversible. Lymphedema is a side effect. This is my absolute biggest platform one. And anybody who knows me knows I really kind of get ruffled when I hear that it's a side effect of having cancer. It's actually not a side effect, it's a disease, and it's a diagnosis, and it needs to be treated as such. Hence why I got so passionate about prevention. Lymphedema is genetic. I'll talk about that in a second. That's a common one I hear in my clinics. I'll have someone come in and say, well, you know, I'm familiar with it because my grandma had it, or something like that. Lymphedema can be treated with medication. I can't exercise if I have lymph nodes removed. I can't carry my purse on the affected side. A few extra myths. I can't fly in an airplane if I have lymph nodes removed. I need to wear a compression sleeve if I have lymph nodes removed. What I eat and drink can cause lymphedema or can prevent lymphedema. I am at risk anywhere in my body if I have lymph nodes removed. So what are some of the facts? Now that we reviewed the myths, what are some facts? Well, early detection is beneficial, and I'll talk about that in a couple minutes. Early lymphedema is treatable, and in some cases, it's completely reversible. Not in all cases, I'm honest in that. But after I go through kind of some things we can do for early detection and risk reduction, I have some evidence of how we can in fact reverse it in many instances. My favorite, lymphedema is a diagnosis, not a side effect. Yes, it can happen as a result of having had breast cancer and breast cancer treatment, but it's not a side effect. A side effect is we have nausea from our medication, or we have constipation. Lymphedema is a diagnosis that requires treatment, intervention, and monitoring. That is a diagnosis and a disease, not a side effect. There is no genetic component. When I say that, it means it's a resource issue in the body. We've removed something from your body, and how does the body respond? Your body is unique to you. Likewise, I'll have patients that come into me and say, well, I had surgery on my other side and I did fine. So chances are I'll do fine on this side. That can be true as well, but it really depends upon how does that side do with the resource that we removed. It's a resource issue. I kind of give the analogy of it's like an air conditioner. If you remove the central part of the air conditioner, does it still function or is it just less efficient? So no two people are alike. There are things you can do to help with prevention. We're going to go through those. My favorite exercise is actually very beneficial. Decades ago, we told patients, not knowing any differently, we told patients that avoiding using the arm, babying the arm or extremity, being very careful and gentle to not overuse it was helpful. We actually know that's not true. We actually know that exercise, getting back to your usual level of functioning, is very beneficial and actually is a risk reducer. You do not have to avoid things you usually do. And this is even for our high risk patients, which I'll talk about in a second. The key that I like to stress to individuals undergoing any kind of nodal surgery is you can get back to your usual level of functioning and quality of life that you had. We may have some recommendations, but you do not need to avoid the lifestyle that you were used to. Some facts continued. Cancer is not the leading cause of lymphedema. Actually, it is a parasite. However, I don't put that slide up. That happens over in most third world countries. In our country, cancer can be a leading cause of it. So can a primary condition where you're born with it as a genetic disease. Most individuals need minimal recommendations as a prevention recommendation. My favorite, needle sticks, blood pressure, flying do not cause lymphedema. They do disrupt the normal lymphatic flow. So most of the recommendations that we give have something to do with keeping a normal lymphatic flow and not interrupting it. I kind of hone in on this just for a second, because sometimes patients will either A, need a needle stick surgery or something on a side that has had surgery, and they become very panicked, or they accidentally get a cut or a scratch. I don't want them to think that they are causing lymphedema. This is not a blame issue. This is not you caused something. Some of the guidelines we have are simply that we know having normal, uninterrupted lymphatic flow is best for an overall risk reduction. Diet does not cause lymphedema. Let's talk for that just about a second. This is where I love having had the background of being a cardiac nurse. One of the most frequent questions I get is, well, if I eat a lot of salty stuff, chips, pizza, I'm going to get lymphedema, right? Well, listen, if you're like me, I walk by an airplane and I swell. If I eat chips, I swell. Lymphedema and edema are not the same thing that happen. They happen for very different reasons. Edema, sometimes we eat too many chips and our feet swell or our hands swell, happens because we have all the resources in the body, but maybe they don't work as efficiently. As we get older, our heart valves weaken a little bit and they don't pump the fluid as efficiently. So if we intake a lot of salt, what happens is the system is overwhelmed and it takes a little bit to get rid of the fluid. That's different than in lymphedema, where we've removed the parts that's moving out the fluid. One is a resource issue, one is efficiency issue. In some extreme cases, diet can be very helpful, but for purposes of early detection, intervention, and early prevention, diet is not a causation of lymphedema. And so for those of you who like your chips, that's probably good news. So what can you do? Now that we've kind of talked about what are some of the myths and some of the risks, what can you do? Well, know your own personal risk. We're going to talk about that in a second. My favorite, remember you're unique and you're not the same as others as you meet in your journey. People are well-intended when they give advice, but everybody has a different journey that they're on. Aunt Betty may have had surgery 20 years ago and may have had a completely different type of cancer, may have had a different type of nodal surgery, and may have had a completely different type of treatment plan. Her risks may be completely different than yours. So remember, you're unique. Be active. I cannot stress enough that getting back to your usual level of activity is one of the best things you can do. Now, of course, this is after you've been cleared from your surgeon's perspective that you're cleared to go back to activity. But whatever level of activity you had, getting back to that can be the most beneficial. Maintain a healthy weight. That doesn't mean we all need to have BMIs that are of 20. That means maintain a healthy weight and recognize that it's important for our overall bodily functioning to have healthy weight. Be aware of early symptoms. We're going to talk about that in just a second. Maintain healthy skin. Maintaining healthy skin is important because we know that the lymphatics are part of the healing system. When we have skin that is closed and intact, it's less prone to infection. The lymphatics aren't working as hard, and there's not a change in the lymphatic pattern. So maintaining healthy skin, wearing sunscreen. If you like to be outside and you know you're going to be gardening, wear gloves. Skin that's closed and intact is less likely to cause lymphatic disruptions. If you're high risk, and we'll figure out who that is next, be aware of the additional recommendations. They're not a lot, but they are important. So what is my risk? Probably most of you watching this today already know your risk, but here is what it is. National average, if you have a sentinel lymph node biopsy only, that's just removing those first few nodes that take the dye during your surgery. We kind of call them the house into the body, about a 6 to 10% nationally. An axillary lymph node dissection, meaning you're taking more than those first few nodes that take the dye, nationally is about 20 to 40%. So what can you do about this? Well, this is where I think talking about prevention and risk reduction becomes. I always in any talk I give, use this slide because I do believe we hit this magical point in breast cancer about 10 years ago when we really realized, wait, we need to start talking about lymphedema. It was the elephant in the room, and I don't want it to be. I don't want patients being frightened of it. I don't want patients having misinformation about it. I want to have open conversations about what it is and what we can do about it. And so we put together what we call, what are the kind of things we can do for prevention? And I'm going to talk about what you can do if you're not doing some type of a formal prevention program, but what can we do about it? One is physiological monitoring. What is your body doing? How is it feeling? Bioimpedance. I'm going to talk about bioimpedance in a second. Educational needs and a multidisciplinary team, meaning recognizing that sometimes we need extra resources. Bioelectrical impedance analysis, what we call bioimpedance. Basically, this is measuring what is the river doing. Remember when I said lymph nodes look like a lazy river? Well, if we measure the resistance of the lazy river, we can figure out when the lazy river is having an increase in its electrical current or an increase in its resistance. By doing that, we can look for subtle changes in someone and figure out, are they at risk of developing an increase in their fluid buildup? We use in our clinics what's called a SOZO or an LDEX. If there's anybody on here, and I didn't see any names that have it, if there's anybody on here who started with me back in the beginning, we called it an LDEX. We now call it a SOZO. Same type of technology. Basically, what happens in our clinics is we use this device to look at what is your level of lazy river resistance before you have surgery. We look at it at key intervals along the way, and we figure out, is the lazy river building up? Detection of this, using this has taught us that we can detect these subtle changes 3 to 4 months before actual physical symptoms start to occur. We've been very successful with this in our clinics. And in a second, I'll kind of show you some of our outcomes that we've had over the last couple of years. So this we can do as a way of having an early detection. This slide demonstrates, and this is actually from our own research, this slide demonstrates when we were able to detect these subtle changes at what we call subclinical. Remember I said that stage 0, which most people never have even heard of, or stage 1. When we detected at that, we're able to actually reverse it. So in our findings initially, we had 25 patients that had these hiccups. Remember I said actual lymphedema rates about 20 to 40% for high-risk patients. We had 25 patients in our clinics that had these subtle changes. We did some basic things that I'm going to talk about in a second. We resolved all 25 of them. We had 17 patients that had some of the subtle changes, a little bit of swelling, probably some symptoms. All but 2 of them resolved. Stage 2 and 3, we were not able to resolve any of them. And that's where I said at the very beginning, we know that early detection and early intervention, for the most part, is reversible. So we've busted that myth time and time again. This is kind of a slide that just puts it a little bit different. And this is true. Subclinical, that stage 0 to early stage 1, most patients never even have a symptom. That's when we have the best opportunity for detection and reversal. Once a lot of symptoms have started, we're really too late for reversal. We can only manage. And that's where an expert like Marcia comes in with lots of therapy and things that you do to maintain. So what are some common signs of early lymphedema? If you're not somebody who has the program that is able to detect it early, what are some things you can do? Well, here's one of the myths that I get a lot. Swelling is not an early sign. Swelling is actually a later sign. Now, initially, postoperatively, you can have swelling. That is not lymphedema. I am talking, these symptoms are after you have healed from your initial surgery. It is not uncommon after surgery to have swelling. So this is usually 3 to 4 months later is when I tell patients to start watching for this. Pain is also not an early sign. Pain is a sign that happens with chronic and later term lymphedema. Burning is also not an early sign. What is an early sign is dull, heavy, unrelenting aching, usually in the arm that is, or always in the arm that is affected, usually in the upper portion of it. It does not wax and wane, and it persists for several days. Sometimes that is a sign that we're having fluid buildup. It's lazy, it's not moving much, and it's just a really uncomfortable feeling. Patients that have it describe it as very unique, and it's just an annoyance. Change in how your ring is fitting. So hands are a funny thing. You can have very subtle swelling and not notice it, but you'll notice it in your jewelry. So usually if you have a ring that's not fitting quite right and it's consistently not doing that, there might be something going on. Lymphedema, for the most part, is a gradual onset. If you have an infection or an injury, you can obviously have a very sudden onset. But lymphedema usually is gradual and it becomes more noticeable over time. One of the challenges with lymphedema before early detection was that, like most people, we kind of notice something feels different where we think, well, maybe it'll get better. Maybe it'll get better. And then people weren't presenting until they had a lot of swelling. And during that time, that's usually when our opportunity for reversal was a little bit less. And so what I really guide patients to look for is just this unrelenting aching that does not wax and wane, and it persists just for a few days. That's the time that really we should start be thinking about some things that we should be doing. So what are some early interventions? And these apply whether you have the benefit of a formalized prevention intervention program or not. Self-manual lymphatic drainage, what we call MLD. This is a basic massage that you can do that helps your lymphatics restore their natural rhythm and flow, and you can do it at home. A licensed massage, what we call a licensed clinical, a CLT, is able to treat that. Most physical therapists that specialize with lymphedema treatment can also teach that. Compression. You see the lady wearing the compression sleeve. Usually compression is also, if somebody has a lot of dull, heavy aching, we'll have them wear a compression sleeve. That usually relieves the symptoms and also helps to restore a little bit of the flow. I describe it as compression helps because you are adding a gentle push to something that doesn't have a pump. And so if you think about your lazy river, if the inner tubes are backing up and you add a little bit of push to some of the inner tubes, usually the logjam gets a little bit better. And so that's what compression does. Stretching and yoga. There have been clinical studies that have shown that yoga, Pilates, and those types of mimics, stretching, have been very beneficial in risk reduction and in the restoration of our lymphatic flow. So usually we will tell patients that a good yoga, Pilates, or stretching program can be good. Weight management if it's indicated, and then monitoring. Are the symptoms getting better? If they're not getting better and it's progressing to either more swelling or mild swelling, that's probably the time to seek out a little bit different. So, oops, sorry about that. I mentioned, how do we know that prevention actually does work? A little bit about our research. This was published, and unfortunately COVID hit us, we haven't had a follow-up yet. This was published in 2018, and this was based off of 149 patients, 149 patients out of our clinics. These were based off of our high-risk patients. 36.4% of them had an elevated score at some point during these 5 years. Only 5% went on to developing chronic lymphedema. So that means that most of our patients with early interventions actually completely resolved and returned back to normal. I do make a note that 50% of our 5.6 were not compliant. And that's usually because this was our very first years of the program. It was difficult to have all of the things in place for patients. Patients didn't really have the benefit of having the increased monitoring, things like that. So we're anticipating seeing even a little bit further reduction in that 5.6 number of chronic lymphedema. So we know that early detection, early intervention, and prevention works. So lastly, if you have somebody with chronic lymphedema that has not been responsive to interventions, there have been some treatment options on the horizon. Now, again, this is nothing that our clinic does. Usually we see these patients in follow-up from the plastic surgeons who do them. There's two advanced treatment options. One is called a lymphovenous bypass, and one is called a lymph node transfer. This slide is a lymphovenous bypass. And essentially what happens, remember in the very beginning of the talk, I mentioned that the lymph nodes they dump into the venous system, where the venous system takes it out of the body. In this slide, you can see what happens is the lymphatic channel is automatically bypassed into the venous channel. And that's the slide in the left-hand lower corner. You can see where that anastomosis has taken place. So they artificially make it happen. Rather than letting the body do it naturally, they make it happen for them. Lymph node transfer, they take a lymph node from a healthy portion of the body and they transfer it up into the affected side. And that can help to restore lymphatic movement as well. Lymph node transfer is not a preferred procedure over lymphovenous bypass, and that's simply because we're disrupting a separate set of beds of lymph nodes. And just like in the arms, anytime you disrupt the lymph nodes, there's always a risk. So lymph node transfer tends to be reserved for people who have either not a candidate for a lymphovenous bypass or who have not had a great success with it, either one. I always like to say thank you for KU letting me do the best that I can do. Without them, I wouldn't be able to do a job that I truly love. And with that, I am going to turn it over to Marcia, where she has some great information on lower body and some other things. Marcia has a wealth of experience in treatment, and it's been a great learning opportunity for me to work with her over the last while, learning about treatment options and interventions for patients who need it, have either progressed or haven't had the benefit of prevention.
Good morning. Well, as Sabrina mentioned, my name is Marcia Beck. I'm one of the lymphedema prevention nurses here at the University of Kansas. My previous life, I worked in Northeast Missouri around Kirksville, if any of you have heard of that area, and actually started a lymphedema prevention clinic in that area more than 20 years ago. So I was able to treat all kinds of patients that had lymphedema. You know, we say that lymphedema is a foreign or orphan disease, but there are over 3 million patients within the United States that do have lymphedema. And it can be from lymph node removals for any type of cancer. So lymphedema can occur in the head and neck. It can occur in the lower extremities. It can occur in the trunk and the abdomen area, as well as the breast, which we have been focusing on today. Some of the things that I participate on nationally is to try to increase awareness for lymphedema. Some of you may be familiar with the Lymphedema Treatment Act. That is a legislative effort to try to get insurances, Medicare, to help pay for things like the compression garments that patients need. I have a list of resources here, and I will email that to Clara so that if any of you are interested in receiving it, you can have it. There are several now organizations that are supportive of lymphedema, patients, advocacy, that sort of thing. So it's really important that we're able to do that. We are hoping that we will be implementing a prevention clinic for also lower extremity. We have not been able to implement that in our COVID environment that we've had the past year or so, but hopefully we'll be able to do that. You know, with lower extremity, I was pleased with Sabrina's tips on prevention for upper extremity lymphedema. You know, with lower extremity, gravity works so well when we're standing or sitting or things like that. So with people that might be at risk for lower extremity lymphedema, more frequent movement is going to be important. Try not to stand in the same position for a great period of time, or sitting for longer than 30 minutes without moving around. So that movement is really important. And again, exercise is great for lymphedema. Think of things like swimming, you know, even just walking in the water, moving your arms while you're in the water actually provides support to your skin. So it's very beneficial exercise for lymphedema. I can't emphasize enough deep breathing. You know, the deep breathing that you're instructed through yoga and Pilates and those wonderful exercises. But deep abdominal breathing actually has the diaphragm pressing on that main duct that carries the lymphatic fluid. The thoracic duct comes up through the abdominal area. So when you take a deep breath, it's pressing on that thoracic duct that gives it a good suction effect, enhancing that lazy river flow. Other kind of gym exercises are great for lymphedema. You know, the bicycling, the ellipticals, treadmills even are good exercises for lymphedema. I've also been a what's called Healthy Steps instructor. That program was developed by a breast cancer survivor who was a dancer. So she put together some very basic moves that could be done from a seated position for people that have lack of mobility, but also moving in the room. And then she combines it with great music and additional props like boas and hats and different things that make that exercise so fun. And then you can do those at home as well. In the Lymphedema Treatment Act on their website, they provide information regarding things you might not know about lymphedema. It is a disease. It is a chronic swelling. Most physicians have not had much training about lymphedema. So those of us and the surgeons, obviously, that go on to treat and study have had additional training, but most do not get a lot of training about the lymphatic system. So when you're out in the community, your primary care provider might not have the knowledge that some of the other professionals do. There is a list of resources available if you're looking for a therapist that you need to treat your lymphedema. There is a certification for lymphedema therapists. It's called Lymphology Association of North America, and that website will be on this list of resources. And they have a voluntary certification test to hopefully test the entry-level competency for those patients that are treating lymphedema. And you know that there is a basic level of knowledge there in providing that treatment. So that website is CLT-LANA.org, and you can get on the website and look by state or within 50 miles of your zip code or anything like that for a certified lymphedema therapist. Other good areas of information is like breastcancer.org. They offer a lot of good support. I recently taped a podcast for them regarding Lymphedema 101. So a lot of these organizations, the American Cancer Society, there is a Lymphatic Education and Research Network, and I believe Sabrina did a podcast and information for that organization as well. So they are increasing their knowledge about lymphedema. I have worked with the Oncology Nursing Society, and we have done a systematic review of the literature and have just recently published, it would have been in 2020, recently published what we called ONS guidelines for cancer treatment-related lymphedema, so that we are trying to standardize care. There's an international lymphedema group. It's called the International Lymphedema Framework that was actually established in England to try to standardize care and offer care throughout the world, including some of those third world countries. We established an American lymphedema framework project based on that international level. I attended the initial meetings, I think it was back in 2008, and we went to England to get some of the basic information and then established a program that is actually based out of the University of Missouri at Columbia. With a database and other information available regarding lymphedema. So there are some resources available for you. And I certainly want to leave some time for questions. So Clara, I'm going to turn it over to you.